Hi, we're going to go over a PowerPoint on occupational therapy in pediatrics in the medical setting. We're going to mostly talk about the NICU, the Neonatal Intensive Care Unit, and the PICU, the Pediatric Intensive Care Unit. The medical settings that an OT might work in would be the acute care hospital, the home setting, long-term or residential setting, and the outpatient setting. I forgot to tell you that most of this information that I'm sharing is from Chapter 3 of your textbook on medical systems. In the acute care hospital, the neonatal intensive care unit is for those infants that are born prematurely and have other major health condition issues and are the most sick babies. And then the PICU, the Pediatric Intensive Care Unit, is a place where a lot of times the babies that have been in the NICU will use it as a step down or a step forward heading out the door of the hospital. The CODA's role in the NICU definitely requires a lot of highly specialized education and now certification, because there's so many complex medical issues that the babies have and a lot of different equipment that you have to know how to use. Also, you have to have a knowledge of how to check for their life sign, like knowing the color of their skin, their respiration rate, and if you see retractions or their chest going in too far, their body temperature, and how they move their extremities around. Some conditions that you'll commonly see in the NICU are cyanosis, which is an infant who turns blue because of not having enough oxygen, bradycardia, a heart rate of less than 100 beats per minute, and then of course there's low birth weight, very low birth weight, and extremely low birth weight, and you can see those weights listed there in the grams. We're going to watch a video of a neonatal therapist, an occupational therapist, that's working with a little girl and doing some positioning with her to help her get into that midline flexion that's important for them.
My name is Marley Fields. I'm an occupational therapist at the Medical Center of Central Georgia, and we're going to demonstrate moving a baby into supine using 2 zappies. Whenever you move a baby, as much as possible, try to move that baby by facilitating flexion during the move. It's a little bit more calm. It might help a baby to maintain physiological and motoric stability. In supine, if you can, you want to look from the head all the way down and see if you can get the head in midline, the hands and arms in midline, and the feet. And you should be looking for good flexion as well. Let me see if I can make her happy. I'm going to use the Zackies to help contain her and give her that midline orientation. We're going to keep her shoulder a little bit forward. Make sure we're not tangled here. arms, you want to see those shoulders coming forward so that she has the ability to bring her hands to mouth. She's going to show us by pulling her tube. And you also want to see if you can keep hips towards midline without too much abduction, as much towards neutral. And we'll kind of use the ends of this to help her so she has something to brace up against. Okay.
As you can see, there is lots of tubes involved in the NICU and a lot of beeping and noises going on. So you can probably be thinking about all the sensory issues that you might have to deal with in the NICU as well. Now, the CODA's role in the PICU, the Pediatric Intensive Care Unit, is similar. It does require, again, the additional education and on-the-job training due to so many medical conditions and different equipment that you have to have knowledge of. You may participate in the screening, evaluation, and intervention. And both the NICU and the PICU are definitely not settings that are for an entry-level practitioner, but they recommend at least 2 years of experience. Some key medical specialists in pediatrics in the medical setting are cardiologists, developmental pediatricians, geneticists, neonatologists, neurologists, ophthalmologists, orthopedists, also the physiatrist, pulmonologist, and radiologist. Pretty much anything with an ologist on the end is what you're going to see. So there's a lot of different specialists that help out in the NICU and PICU. Some medical terms and equipment that you might need to know to be in that environment. Of course, Medicaid, which is the primary reimbursement for pediatrics for disabilities. Apnea monitors, which a lot of families end up coming home with, that monitor the child's respiration rates. The IV lines, which pass through their skin into veins to give them fluids and medication. The pulse oximeter, which measures their pulse and oxygen saturation levels. The feeding tubes, there's the oral tubes that are placed in the mouth going to the stomach. The nasal tubes placed in the nose going to the stomach. And then the surgically placed G tubes that are placed in the abdomen going to the stomach. They also use a lot of UV lights to help with children who are having jaundice. Then there's the warming blankets and lights, because all of those premature children cannot control their body temperature at that point in time yet. One of the most important things that we had talked about too was to be able to know how to check on that child to see for signs of distress and concern. So you need to be able to know their heart rate and what for that child should be the normal heart rate for them. Their oxygen saturation levels, and know again what is normal for them. Their color, what is the typical color of the child's skin when they're not in distress. Their skin temperature, it should be warm to the touch unless they have a condition that would affect that. Their breathing patterns, you should kind of know, do you typically see retraction with that child? You know, do they have some pulling in of the chest when they breathe? Is that normal for them? Their affect, are they more cranky or more irritated today? the sleep-wake cycles for that child, which is very hard to establish, in the NICU or the PICU with, obviously we had mentioned all of those sounds going on and all of those tubes and all of the lights. That's something that the occupational therapist does work with a lot, is trying to create a better sensory environment for that child to get some more normal sleep-wake patterns, and then also movement patterns. Now we're going to watch one more video, and this is just kind of talking about some of the ways that you have to be able to look at a child in the NICU and know if they're in a place of distress or concern. They're going to talk about some things on here that are not necessarily things that you need to know, or a little more information, but there is some very good information, like checking on the color and the respiration rates, and looking for retraction of the chest.
The goal of this module is to learn how to perform a focused physical examination of a stable preterm infant. Our patients today are 31-week gestation premature twins who are a few days old. On general observation, you can see that the infant appears well and is alert and active in the supine position in his isolette. He demonstrates some jitteriness of his upper extremities. He has some mild retractions, but is not requiring any respiratory support. He has a nasogastric tube in place for enteral feeds, and electrodes for monitoring his heart rate are on his chest. There is a pulse oximeter attached to his foot and a temperature probe on his flank. The dried remnant of the umbilical stump is still attached. There are no obvious dysmorphic features. Examination of the oropharynx reveals no clefts or other abnormalities. The skin appears tinged with jaundice, but there is no evidence of cyanosis or anemia. There is a patch of erythema toxicum on his abdomen. There are no birthmarks or other obvious lesions. The cardiovascular system is generally evaluated first, as the heart sounds are more difficult to hear if an infant is crying. Auscultate the heart after you have first noted the position of the apical impulse, which can quite often easily be seen in the preterm infant. Remember to specifically listen for the valve closing sounds S1 and S2, extra sounds S3 and S4, murmurs, arrhythmias, clicks and rubs, and palpate for precordial heaves or thrills. Remember to assess capillary refill and check your femoral pulses for symmetry and brachiofemoral delay. You can see periodic breathing in our patient. This is reflective of breathing immaturity. Assess the infant for signs of respiratory distress. These include expiratory grunting or moaning, nasal flaring as demonstrated here when the infant is sucking. As you can see, our infant has both intercostal and subcostal retractions, but is not requiring any respiratory support to maintain appropriate oxygen saturations. Also look for any asymmetry of the chest, which may suggest a pneumothorax. Auscultate the lung fields, paying particular attention to any asymmetry in air entry and breath sounds, and any added sounds such as crackles or rails. Examine the abdomen.
So as you saw in the video, it can be a little bit difficult to assess young premature infants, and so that's why they recommend the special training and also for you to have experience. You want to assess areas like their cognitive ability, their sensory system, neuromuscular, cardiovascular and respiratory, voice and speech, digestive, and elimination functions. That's the end of the PowerPoint. If you have any questions, just send me a message on the discussion board, or you can send me an email. Thank you.